From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome back to another episode of JNC Cardio Connect. I am Marcelo Di Carli, and I am the editor-in-chief of the Journal of Nuclear Cardiology. And today, we're going to take a special topic on this conversation. Over the past few episodes, we have talked a lot about data, about innovation, and about how technology drives best practices in our field. Of course, technology excellence, safety, and outcomes are essential pillars on which we build best practice. But that's one part of the conversation. There's another dimension that often gets less attention, and that is the real world value of what we do will often hinge upon how clearly we communicate our findings to guide care to providers and now also to patients as well. Ultimately, I think we all agree that the true impact of our work is in how test results can really shape clinical decisions and improve outcomes and empower patients to really take part in this journey of their own care. That's the topic, and that's where our conversation will begin. Joining me today, we bring unique, thought-provoking people in this field who have been pioneers on this concept. Joining me is John Spertus, who is professor of medicine at University of Missouri, Kansas City, and he's also director of outcomes research at St. Luke's Mid-America Heart Institute. Also with us is Krishna Patel, who used to be a mentee of Dr. Spertus, and now she is an assistant professor of medicine at Mount Sinai School of Medicine. Welcome to both of you to JNC Cardio Connect. I truly appreciate your time today. And for our audience, this is not a paper we're going to be discussing, but rather a perspective that John and Krishna published in the journal in the month of September. From my perspective, is a must-read piece because it really marks how we ought to be thinking about shaping our future in the field. So John, give us a framework of when you started thinking about this and why should we all be really thinking about this notion of patient-centered reports in imaging.
Thank you very much, Marcello. And you neglected to say that Krishna used to be a mentee of mine, but is now my mentor. So she's the one who's guiding me and thinking through a lot of what we're doing. But in reality, I have always been very, struck, motivated to improve the patient-centeredness of care. And when you think about nuclear imaging and really all diagnostic testing, I mean, by its very nature, it's not a treatment. It's a means to understand what's going on so that we can actually better devise, tailor, and deliver treatments. And so if you sit at the threshold of knowledge that can really help make a diagnosis or guide therapy, it's incumbent on you to make sure that the recipients of the information understand what you've learned so they can do the right thing. And so from my perspective, cardiac imaging is answering key questions. Does this patient have coronary disease? In which case, secondary prevention needs to happen, and the patient needs to know the diagnosis, and the doctor, the referring physician, needs to implement the therapy. Does the patient have very high-risk disease, left main or multivessel disease with LV dysfunction? And there's an urgency to really consider revascularization, or does this patient complain of a lot of angina, have no evidence of ischemia, and maybe we need to be thinking about microvascular disease or coronary vasospasm? And so as an imager, you have the knowledge of what should happen next. And there are many users of that information. Obviously, the primary care referring physicians have to know what's going on, what should we do. The cardiologists want to know, do I need to take him to the cath lab? The patients need to understand their diagnosis, prognosis, and what they can do to help improve that, as do their families. But what ends up happening is that the imagers tend to write the reports in a way that supports the quality of which they've conducted the study and supports the billing for the study. It doesn't really meet the needs necessarily of the primary care or cardiology referring physicians or the patients or their families. And so to me, that voltage drop of insight and information from the people who've discovered it to the people who need to use it is what really felt to me like a great opportunity to improve the way we deliver or restructure care.
When we collectively started thinking about this, I said, this is really important, is how do we translate the complex information into actionable stuff that patients and physicians can act on? So, Krishna, now we're going to turn to you. You've been doing lots of interesting work and thinking about this. So why don't you summarize for us where we are as a field in this particular topic?
Thank you, Marcelo, for having me here and talking about this very important topic. So in nuclear cardiology, we know that our technology has evolved over the past several decades. We now have PET. We've not only gotten better with our diagnosis, risk stratification, we have more data, right? We talk about flow, EF, perfusion, but our reports haven't really caught up with the times. There's still filled with a lot of technical details, technical jargon about the tracer that we use and the protocol that we use and the different findings of the different imaging information that we get. Yes, it's all important for the imagers, but it's important to realize that it could get really overwhelming for the patients if they see that information and they don't understand it. And sometimes even for referring doctors or clinicians, even cardiologists and internists who are necessarily not imaging experts. And eventually it leads to gaps in care, which is what we really want to address here. We know from studies like Spark that you led a couple of decades ago now, that more than half of the patients don't get appropriate follow-up or appropriate treatment based on the imaging information that they receive. So now that our imaging has become state of the art, we have to talk about improving our communication. And our reports are how we communicate to our patients and to our referring doctors. So that's what patient-centered reporting is all about. We want to translate the complex imaging data into clear, actionable information for our patients and for our referring doctors. We try to do a pilot and ask our patients, what information do you find meaningful? They want plain language summary that they can understand. They want visualization. We often kind of put all our information in words, but they would like to see more visual data, personalized risk if that is available. And then our patients also like to know, well, what should I do with this information? And what do you think would be the right next step? So all of these things are important when you're thinking about how a patient-centered report could look like.
Krishna hit on an important point I just want to emphasize. Yes, the patients want to know what's going on and what to do next, but so do our referring docs. I think we live in a silo where we understand the incredible nuance of a TID or balanced or unbalanced ischemia or percent myocardial perfusion. It's not that it isn't amazingly valuable information, but it's lost on me. I don't know intuitively what to do. And as we want to provide more patient-centered, high-value healthcare, if it's not done, then it's not acted upon. The test is no longer a high-value test. It's not helping us manage the patient according to their needs, risks, and preferences.
One element for our audience is that what we're talking about here is not proposing to replace the important content that still goes into the report, but we're trying to also translate information that sometimes gets lost because we just don't know what to do with it.
I have one more dream I'd love to share. As you may know, I was very involved in the design and execution of the ischemia trial. And the ischemia trial was designed to figure out how should we manage a patient after a diagnostic stress test. At the end of the trial, we did a lot of work with patients, like what outcomes would help you decide to go to the cath lab or not. And it was basically the top things were survival and quality of life, followed by physical function and angina. So we took all of the data from ischemia and we built a model to show for this particular patient with this burden of angina, diabetes, and this amount of ischemia on their stress test, what would their 4-year survival be if they go to the cath lab or not? What would their 1-year quality of life be compared to today if they go to the cath lab or not? And it fits on one page. And if imagers could essentially have a patient-centered report, and then when ischemia was present, this one-page tool that leverages 5,000 randomized patients to show what their outcomes would be for patients like them, then there's the tool available for the guideline recommendation of shared decision-making to occur to be there. And then you're giving so much value beyond just the diagnosis, but you're giving the tools that doctors and patients can use to really elicit preferences, define a pathway, and then if they choose not going to the cath lab, you follow them, and if their angina is not eliminated, then you go to the cath lab, but you really are giving the tools that can allow the vision of the guidelines to be realized.
John, what you just mentioned reminded me a casual conversation I had with the spouse of a physician here in the hospital at a reception this past weekend. And we were talking about imaging and test results and all of that. And she's somewhat informed, but she told me, I discovered a tool using AI. I plug in the test results and I get back information that I can understand. And she said, and that helps me when I go to my doctor to ask the right questions, because now I'm a little more informed about what the test results meant for my particular situation. Krishna, this is early days in this field. What do you think we need to do to move these forward?
Definitely. Marcel, you brought up a very important point, right? We need to make this patient-centered reporting concept more practical and scalable so that more people can operationalize it and adopt it. And you brought up also another kind of interesting point about using AI or large language models to help with that. So now that we have the technology, we could perhaps use it to help us generate these kind of patient-friendly reports. But it's important to note that they might not be 100% accurate, right? So it's important to know that we should vet it appropriately. But with our oversight and approval, then we can decrease a lot of our workload and scale provision of these kind of patient-friendly report supplements to our patients and our referring physicians on a large scale. I think that's kind of more immediate and actionable things that we should do right away. The other thing is we do need real world evidence so that it works, not only to improve patient understanding and patient satisfaction, but also really improve outcomes, right? And what outcomes are we looking for? We want to see whether that gap that we talk about in terms of what the data shows and what the actual appropriate treatment is that gap narrowing? Are patients more adherent to the treatment that they should be getting because now they know what they should be doing and they understand their test results better? And eventually, we want to also see harder outcomes in terms of reduction of unnecessary procedures, improving patient symptoms, function, quality of life, and survival. The other key piece that John had highlighted before is, we want to also make sure that it works for our referring doctors as well. Towards that end, I feel something like a CAD-RAD system of sorts, but for myocardial perfusion imaging, where we have standardized categories of reporting across PET and SPECT, standardized interpretation, as well as standardized text on what to recommend. That can help us communicate the risk associated with our test consistently across different readers in a way that is not only easy to interpret, but maybe potentially also help bridge this imaging and treatment gap that we talk about.
I would just go one step further. I think that you've got to make it really easy for docs to do it. And towards that end, I think that ASNC ought to lead what the construct of something like this should be, and then create a very simple tool that can be accessed by the imagers in generating their reports. There is an economic argument that could be made where it could offset the workload to do this. And it takes a while to set it up, but once it's set up in a lab, then accessing it can become routine. That's what I think needs to happen, because as I've gotten older and older, I don't want to keep doing studies necessarily to prove its value if it's self-evident and there's a business case to do it. And so I think there's a real opportunity for the professional societies to create this, to do the heavy work up front, and then for practices to have an easy means of implementing this vision.
This is a great place to end the conversation. I'm really very thankful for your time today, and also for putting together that thought-provoking perspective. We tend to think very traditionally what best practice is, and what we have right now is one important part of best practice, but it's not where it ends. We need to now go to the next level, which is how do we finally realize the value of what we did by enhancing the way in which we communicate that information to our audience. So thank you again for your time. It's been a very refreshing conversation. And until next time.
Thank you so much.
A pleasure. Thank you so much.